Good evening, listeners. It's a long time with restarting the Neuro Partsala. Recently, I lost my father, so I was in a state of mourning for a month. Then life goes on, so we are back to academics. The world acknowledges 21st September as World Alzheimer's Day with a goal of raising awareness of the disease, common symptoms of the disease, and risk factors. So, this endeavor is in the memory of Alzheimer's disease, and so let's see what we can think about dementia and cognition. You know, we'll try and define dementia, and we'll think of current concepts, the neuroanatomical correlates, the current concepts in neurophysiology, current concepts of memory, clinical dementia syndromes, and we'll leave the neuropsychological assessment to next class. The dementia syndrome, when do we suspect it? When a patient comes to us with a change in performance of everyday activities, that is, his inability to perform household tasks, there is an inability to cope up with small sums of money, there's an inability to remember short list of items. For example, the shopping list, he usually fumbles, or he does a lot of mistakes. There's inability to find a way about indoors and also outdoors. Ability to interpret surroundings, to recognize whether he's in hospital or at home, or to discriminate between patients, doctors, nurses. That means identification problems. He's not able to recall recent events, for example, recent outings, the visits of relatives, etc. And there is usually a tendency to dwell in the past. There may be changes in habits in eating, and he may have to be fed in advanced stage. He has to be fed cleanly with proper utensils. One should eat, but he becomes messy as the disease progresses. He can manage only with spoon, then he can only manage simple solids. And dressings can becomes again a problematic area. He will be unaided initially, but occasionally misplaced buttons, wrong sequence, commonly forgetting time, items, unable to dress the advanced stage. The control over sphincters becomes slow, gradually deterioration with occasional wetting and doubly incontinent in late stages. So these are symptoms with which one gets the patient to us, and these are very very important aspects, that when you have to suspect. What are the changes in the personality, interests, and drive? He becomes very rigid in approach, egocentric, and he becomes affect is disturbed, and he will not have any regard for feelings of others, and there is emotional control which is impaired, maybe irritability or increased petulance, and jocularity in inappropriate situations. There may be responsiveness exposed to emotions which will be diminished, and maybe sexual misdemeanors, hobbies are relinquished, and apathy growing rapidly and purposelessly hyperactivity at times. So these are some of the things with which an individual comes to us as for dementia workup. So now you have seen that it is a disabling impairment of multiple cognitive functions. It's not memory alone. Memory has got its specific aspects, is it a immediate recall, or is it learning ability, or is it retrieval part? But it's not only that. There are other aspects which you are going to see in the coming slides. There is mild cognitive impairment, that is MCI. It can be in single domain like we said, multiple cognitive functions, multiple domains will be involved. Here it could be amnesic, that is only memory loss, or it could be non-amnesic when languages, executive function, and visual spatial functions, or it could be multiple domain MCI involving both amnesic and non-amnesic. So when disease is suspected, by the time Alzheimer's disease, already disease is in progress. So there are neuropathological changes that are taking place which can be picked up by the PET scans, tau PET and amyloid PET. Could be biomarkers, there could be neuropsychology which can give you a clue, and a cognition, that is the manipulation of fund of knowledge which one acquires, and in the light of the new knowledge or new things he's learning, he has to manipulate that and give new information. That's what is cognition. So these are things that can happen, that is a dementia. And let's see the areas where it can be affected. It can be, as you say, frontal, parietal, and occipital lobes and temporal lobes. These are the immediate that comes into your mind, that brain is divided into these areas, and there are disturbances which will suggest that this is frontal, this is parietal, this is occipital, and these disturbances are varying from impulsivity, poor judgment, inattention, abulia, and Broca's aphasia and frontal dysfunctions, and Wernicke's aphasia and topographical disorientation, somatognosia, and apraxias, acalculias, etc., and parietal lobe, and cortical blindness in occipital. And nowadays, the three important aspects are coming into vogue, that is, right and left cerebral hemisphere functions are being studied separately. Also, the function of executive control function, which is becoming more and more relevant in our understanding. And there are also functional zones in the brain, and the brain networks are connected to these functional zones, like heteromodal association areas, which are anterior and posterior, unimodal association areas, which are surrounding the primary sensory areas, and the supramodal association areas, which are in the anterior part of the brain, especially the dorsolateral, the prefrontal regions, orbital and medial frontal, and anterior temporal lobes. These are the areas which are very important for cognition. And so these are the new concepts that are developing. So in short, what should a dementia syndrome have? The short and term and long term memories. There are various types of memory disturbances which we'll discuss, but one of the important aspect that dementia syndrome or the definitions has, that is that memory disturbance. And executive functions such as abstract thinking, judgment, problem solving, the dorsolateral prefrontal lobe functions, the higher cortical functions which are in the realm of association cortex, that those are very important. And those higher cortical functions will be aphasias, apraxias, agnosias, construction abilities and calculations, etc. So these are the some of the important uh, components of a dementia syndrome, because dementia is not a disease, it's a syndrome. It has got various presentations, and some of them may have behavioral and emotional functions. The emotional control may be disturbed, and social behavior is abnormal. They may not be motivated enough, the personality disturbances. And activities of daily living, work relationships, social activities, all can be disturbed. The other important aspects one should remember is there should be a progressive deterioration. The duration of symptoms should be at more than 6 months. Decline in a functional status, normal consciousness. Sometimes the residents keep coming and saying they've got dementia after only 1 or 2 or 3 months. So there is a different category which we'll take up in the next subsequent classes, that is called rapidly progressive dementias, and which is a separate category which we'll take later. So after this, we'll see the current concepts of a definition of dementia. Do we have a clear-cut definition of dementia, and how the definition has evolved over course of, and what is main concept now so far we understood is it's an acquired loss of cognitive and emotional abilities. There is impairment in multiple domains of cognitive function, but there is no impairment of consciousness in primary degenerative dementias. But this functional problems are severe enough to interfere with daily functioning and the quality of life suffers. As I said, dementia is not a specific disease or a pathological process. It has got more than 55 etiological factors. And if you look at this, like a frontotemporal dementia, dementia with Lewy body disease, Alzheimer's disease, Pick's disease, and apart from that, there are many other causes for dementia, and all types of dementia are treatable at least with psychosocial interventions. There are various types of definitions that exist for dementia in literature, and the DNB neurology residents are supposed to learn all the definitions and try and differentiate what are the different differences in these definitions, and the latest being DSM 5 criteria. So the DSM 3 and 3R definitions of dementia, which is identical to DSM 4 definition, is found to be reliable and should be used routinely by another guideline. So let's have a look at these definitions. 1981 has brought out the Diagnostics and Statistical Manual that a deterioration of previously acquired intellectual abilities of sufficient severity to interfere with social or occupational functioning. So the intellect is again a big concept. Intellectual abilities, that means the fund of knowledge which has grown in various with the age and the manipulation, the cognition, the execution, all these constitute intellect. The second is memory impairment, and at least two of the following should be present. That is impairment of abstract thinking, other cognitive deficits such as impaired calculations, apraxias, or anomic aphasias. This should be impairment in judgment or impulse control problems, personality changes. Any two. They should not meet criteria for intoxication or delirium, although these may be superimposed. And what are the following? That is evidence from physical exam, laboratory tests, or history of a specific organic factor that is judged to be etiologically related to the disturbance, or in the absence of such evidence, an organic factor necessary for the development of the syndrome can be presumed if the behavioral changes represents cognitive impairment in a variety of areas, and if conditions other than the organic mental disorders have been reasonably excluded. So we have to, by all means, exclude all the concerns. So what is it different? The revised definition 87: a syndrome produced by many disorders characterized by impairment from a previously higher level of intellectual functioning. The impairment involves memory, that's important, and other cognitive domains like language, orientation, constructional abilities, abstract thinking, problem solving, and praxis, and must be of sufficient severity to interfere with occupational or social performance or both. That is functional impairment. So now you see the definition slightly, but still it is hovering around memory. And if DSM-4 said multiple cognitive defects that include memory impairment and at least one of the following, like aphasia, apraxia, agnosia, the disturbed executive function, these are all higher cortical functions. There should be impairment in occupational or social functioning, should decline from a previously higher level of functioning. So there are various definitions. Now, when you sit in the OPD and a patient is brought and you suspect that there is a dementia. Now, if you apply all these definitions, various definitions, there are others also which I have not mentioned, like ICD and NINST, ADR definitions, which if you apply, how many of them concur? And is there any uniformity in coming to a conclusion whether this individual has a dementia or not has been studied in 100 patients. So if you suspect 100 patients to be having dementia because of the various domains that are involved, the ICD diagnosed only 3% to be having dementia. Camdex only 4.9, ICD-9 5, DSM-4 13.7, DSM-3R 17.3, and DSM-3 29.1. That means if you suspect dementia, the definitions that were existing before the current definition, which I'm going to tell in the next slide, there is no uniformity of coming to a conclusion. This applies mostly for the primary degenerative dementias in the initial stages of Alzheimer's disease and Pick's disease and things like that. Then there will be difficulty in communicating with your peers also across whether what is happening in this. But 2013 has brought a new change, and we that means we are told that you should not use dementia anymore, but you use the major neurocognitive disorder. So in this, the memory has been downgraded. One or more acquired significant impairments, that means independence is lost in cognitive domains such as memory, that is amnesia, language, aphasia, apraxia, execution of purposeful movements, agnosia, recognition and familiarity, topographical disorientation, visual, spatial function, self-control and management, that is executive functions that are impaired, and a dyscalculia, dysprosody, agraphia. All of these, one or more acquired significant impairments in any of these domains will tell us that he has a dementia. That is DSM-5 criteria, which all of you should know what is a major neurocognitive disorder. Now let's go to neuroanatomical correlates of dementia and let's see how over the course of centuries how it was evolving. But one you should know that cerebral cortex is a layer which is surrounding the surround all around the brain, and it has got a lot of neurons. And in fact, if you look at the 70% of body's neurons in the cerebral cortex, and most 75% of them are in association cortex. So your joys, your sorrows, your sense of personal identity, the free will are in fact no more than the behavior of a vast assembly of nerve cells and their associated molecules, so said Francis Crick. So if you look at the 18th century, before 400 BC, before Christ, to 18th century, the brain function is thought that the thinking and the intelligence and everything is cardiocentric. Slowly it was brought to lateral ventricles, that is sensation and perception. The reasoning they thought was in third ventricle, the memory was in fourth ventricle. So we were they were thinking in these lines till 18th century. The localization of a historical aspect, you can see the numbers given here, that is number 1, 2, 3, 4, and the benevolence is given 19th number, the form is given 25th number, the size is 26th number. So they were the localizing of behavior in the brain in 1800th century by Franz Joseph G, and slowly the knowledge about the brain, behavioral and memory and cognition has started improving. It's Paul Broca in 1860 who said golden era of localization is started when the left cerebral hemisphere is found to be dominant in the right-handed individuals. And in left-handed individuals also 60 to 80% they have the left cerebral hemisphere dominance, and now started learning things which are right cerebral hemisphere relevant and left cerebral hemisphere relevant. For example, the verbal memory is localized to the left cerebral hemisphere and the visual memory to the right cerebral hemisphere. Like that, you have prosody, construction on the right cerebral hemispheres. So now the Broadman areas have been identified subsequently. The frontal lobes, they got thinking, planning, motor execution, executive functions, and the mood control. All these are there. The anterior cingulate gyrus, and which has very important in volitional movements, attention, long-term memory. So what you are today and what are human beings are because of the frontal lobes. The frontal lobes are key to our memory. The Though we think the temporal lobes are important, the frontal lobes are very important, and you can see the parietal lobes, the sensory primary sensory areas. You can look at that. Post central sulcus, post central gyrus is the somatosensory location. Visual cortex, occipital, the auditory is temporal. All these are primary sensory areas, and olfactory lobes are there. So these primary sensory areas are posterior to the central sulcus, and they are very important, as you understand, when we discuss the functional zones of the brain. And you can see the occipital lobes are helpful in visual perception and spatial processing. There are two streams of functions that go with the one thing is dorsal stream and one is ventral stream. That is the pathway which goes like this and like this. Dorsal is the where pathway and the what pathway. So you can have these pathways, and we'll discuss them in the subsequent slides. Okay. Right. So now if you look at the functions of left cerebral hemisphere and right cerebral, that is a recent concept, and their various neurobehavioral syndromes are distinguished by the appearance of these various symptoms, and you can categorize them: distractibility, perseveration, lack of drive, impulsiveness. These are all frontal lobe dysfunction features which are seen in the A or number one here, and this is a frontal lobe. Aphasia, agraphia, alexia, apraxia, acalliclia, finger agnosia, right-left disorientation. These are all parietal lobe. You can see the parietal lobe that is present here. And this is the lateral aspect, this is the medial aspect. And you can see the hemispatial neglect, visuoconstructive disorders, topographic gnosis. These are right cerebral hemisphere prosopagnosia. So these are all right cerebral hemisphere dysfunctions. These are a number, I mean, that you can see that. And pure alexia, associative agnosias, color anomias, visual recognition disorders, these are occipital lobe problems. So the broad idea you have developed now, and we'll see the what's going to happen next. The left cerebral hemisphere, broadly, you remember this. It is affect is parasympathetic, calming, and affiliation it dictates. And it's important for verbal memory, narrative, symbolic, and it is important for skilled movements. And it whatever it does, it is in the local arena. Where the right cerebral hemisphere is important for sympathetic function, defensive responses, arousals, visuospatial functions, the social environment interaction, the and in socially environment, a global perspective. So these are all concentrated on the right cerebral hemisphere in a broad way. So, how is that possible now? The brain network theories have come. Now, we were brought up from the childhood that the frontal lobe has got these functions, occipital lobe has this function. But now the concept is that large areas of networks are present, and these networks, you can remember the five cognitive domains to be kept in mind when you think of dementia: memory, language, the attention and concentration, which is in the prefrontal region, spatial cognition, and executive control function. So these are important five cognitive domains, and which you have to remember. And the networks or connectivity is frontal region with subcortical regions, the memory, that is the limbic system, the Papez circuit, the language, that area is connected from the superior marginal gyrus to the inferior frontal area through arcuate fasciculus. The visuospatial thing, which has got a dorsal pathway and a ventral pathway from occipital cortex, goes to parietal lobe. That is the dorsal pathway, that is where pathway, that is perception. Where is in space, where is this particular thing? What pathway? What is that? That is visual path, that is going to from occipital cortex to the temporal lobe. That's the visual pathway. That is where pathway. And intrinsic connectivity, which we can show that frontal is connected to the basal ganglia, the thalamus, and going back to the circuits. So you see the perisylvian language network. You can see the primary auditory cortex where you are listening what I am telling you, and through the auditory belt, and it goes to the prefrontal cortex, premotor cortex, motor cortex. If you get bored, you will put off the laptop. So it's like that, no? Network architecture in the perisylvian area. Language, that means two-way communication from individuals, is facilitated by this area, that is the superior temporal gyrus area 18, 17, arcuate fasciculus. It's going to the inferior frontal region area 44 and 45. So these are the areas that are connected, interconnected, and through various like circuits. So these are circuits like, you know, electric circuits. Remember, these are circuits like that. The second important thing was the retentive memory or the limbic network, which will be hippocampal region and hippocampus, and it goes and phonics, and it comes back to the mammillary bodies, and it goes to anterior the cingulate the anterior nucleus of thalamus, and from there it goes to cingulate gyrus. So this is, again, I'll show you in the next diagram. and you can see the hippocampus, the phonics, and which is coming into the mammillary body and goes to the cingulate gyrus, and these are the mammillary bodies, and it's ending, the phonics is ending here, and this is the amygdala. These are all interconnected, and this is a supramodal heteromodal, I mean supramodal association cortex it is called, which I will touch in the coming slides. So once again, a very important circuit to remember. Again, I am telling you, this is the hippocampus and the phonics, and which is lying below the corpus callosum. There is a septum pellucidum that attaches and that separates between two things, and the septal area is here, and the mammillary bodies, and from there it goes to anterior nucleus of the thalamus. From there, the cingulate gyrus is connected. Anterior cingulate gyrus and insula areas are very important for empathy circuits, and you will see them. These are the circuit. That's another important circuit which I have seen. The parieto-frontal, that is spatial cognition, which is coming from the supplementary motor areas, motor premotor cortex. The connections go to basal ganglia, red nucleus, and of course the spinal cord, and also has connection to cerebellum. Finally, they enter the limbs, the muscles, the motor behavior is musculoskeletal mechanics, or mediated through this circuit, that is the parieto-frontal spatial cognition circuits, especially on the attention and behavior run. This is in the premotor area, this is in the prefrontal area, and this area is intensely connected to all areas in the brain. You can see the auditory association area. Now let's understand one thing. When I ask what is association cortex, many people don't know what is association cortex, right? You see that there is a primary sensory somesthetic area, post central gyrus. This is a primary Wernicke's area or the primary auditory area. This is a visual area, which is yellow, it is seen. There is one more olfactory area. And this area is called the primary sensory areas. Surrounding these areas are unimodal, that the percepts are stored there. Whatever you see, whatever you hear, whatever you feel, that has to be stored in the brain for you to recall and feel. So those are stored where a large number of neurons are present surrounding the primary sensory areas. These are called unimodal association areas and association cortex, which is storing the memory of those percepts. And one percept should link with the other percept, that is the cross modal association. Then only you can say, suppose if you are asked, a chap is sitting, he's going on the river, he's got a wood in his hand, and what is that? Then you remember that, oh, that is a boat and he's rowing. So to say that cross modal association, there should be connections between the visual, the sensory areas and the auditory areas, everything. So they are interconnected. That is called association areas, which we'll talk later. And the face and object recognition, that's what I was saying. Striate cortex is very thickly connected to the temporal lobe as well as the parietal lobe. One is a dorsal pathway, the other one is a ventral pathway, and that is the visual spatial function is another important domain which gets involved in cases of dementia. So the intrinsic connectivity network. Now we have seen that the circuits, the wiring that is being done. So there is a salience network, that means that is a cingulo-opercular network. Second one is a default mode network. Third is executive control network, that is front to parietal, the affective limbic network, and you see the regional nodes of them. The salience network, which is important for empathy, is connecting the mid cingulate area anteriorly to the anterior insula and frontal operculum. And what it does is this network vibrates, and it bodily directed attention on behavior and a state of representation, body state of representation, and body guided attention. These are things which are they are very, very important things that it mediates. The default mode network is conceptualization, self-referential, next one, spontaneous thoughts, the default mode. This is medial prefrontal, the posterior cingulate gyrus and precuneus, which is a part of the parietal lobe, and medial temporal lobe, the spontaneous thought. This is the default mode network. These are the regional nodes. The executive control is dorsolateral prefrontal cortex and inferior parietal lobule precuneus. That is the frontoparietal control network, and which mediates the executive control function, also working memory, task switching. If this network goes on berserk, what you get is acute confusional state. Affective limbic network, that is the sub before the the genu of the corpus callosum in the anterior cingulate cortex, medial and lateral orbitofrontal regions. That is the motivated behaviors this network is mediating. So you see that then nowadays the cognitive neurology is revolving around the networks that which should. Hello.
తెలిసిందా తెలిసిందా
Hello.
now
So you see the salience network, we have default network, how they are connected. The prefrontal region is connected to the caudate nucleus and globus pallidus, ventral anterior nucleus of thalamus, and is going back, and is also going back to orbitofrontal region. So they are interconnected, and on this side you got the cingulate gyrus and the insula, which both are important, and mammillary bodies and hippocampal formation. So various areas are interconnected, and dysfunction of these areas will give rise to the behavioral problems. And this is the intrinsic connectivity network theory, which I was trying to, I have already mentioned them. So the salience network regulates homeostasis and produces emotions. Now how we see the vagus nerve is getting impulses from the periphery. This nucleus of the solitary tract and parabrachial nucleus and ventromedial nucleus of the thalamus and mid insula and posterior insula. You can see them fronto-insular region. The insula is very important. Pre-genu of the corpus callosum in the anterior cingulate cortex, the central nucleus of the amygdala and hypothalamus, periaqueductal gray matter, dorsal motor nucleus of vagus, nucleus ambiguous, nucleus of the solitary tract, which are present in the medulla, intermediolateral cell column vagus nerve. So all these things are maintaining the homeostasis, and the visceral sensations are conveyed to the brain, and this is an important aspect of supramodal association cortex. So these are the connections which one should remember. And the network dynamic model, there's a default mode network, salience network, central executive network, which are maintaining the behavior, and the both endogenously mediated and exogenously driven cognitive functions are mediated by these networks. I have sensitized you enough. We'll go on to the other things. The networks will the important networks I have mentioned here. The singular opercular system plays a central role in switching from an interoceptive stage to a goal directed state. This system is hypothesized to initiate a dynamic switching between default mode, which is inherent to the frontoparietal system, which is the executive, what you have to do. So these are the things which you have to concentrate and learn. Then let's go to the neurophysiology of the cognition. What is neurophysiology? You see, the primary cortical sensory areas which I was mentioning earlier, visual, auditory, somatosensory, gustatory, and olfactory, and surrounding these areas there are neurons, large number of neurons surround the primary cortical areas, forming the unimodal association cortex, where the unimodal percepts of those sensations are stored. And this heteromodal association cortex is divided in two areas. The posterior one is very important, which is in the left inferior parietal lobule or angular gyrus. So if left side angular gyrus and parietal lobule are disturbed in strokes and other things, you'll have lot of disturbance. Lot of disturbance. The anterior heteromodal association cortex, which is in the perisylvian area, the frontal lobe areas 8 and 9, is important for sequential processing of the cognition. So we'll see what is that. And as I showed you, supramodal association cortex is receiving the salience network from the viscera from the emotions and other things, and mediated this area is anterior, medial, orbital, prefrontal regions, and also temporal poles. That is the supramodal association cortex. So all the cortical cortex, association cortex, is divided into these areas. Sometimes association cortex comes as a question, as a question. You may have to write that. Okay. So the functional subdivisions, as I see, the primary cortex receives and transfers primary extroceptive, that is sensory and motor stimuli. We'll see this memory. When we deal with memory, you can see this. The formation of unimodal percepts takes place unimodal association cortex, which is surrounding the primary sensory and motor areas. The heteromodal association cortex is divided into posterior and anterior. The posterior one deals with cross-modal associations, and the anterior one deals with sequential associations. The supramodal association cortex, which is in the frontal lobes and temporal poles, receives, transfers interoceptive sensory information. They come from within, the visceral sensations, emotions, and other things that are coming in the body, extroceptive and interoceptive. So you should remember that. So these are the cortical functional zones which are depicted here. Multimodal association, motor and sensory, limbic, paralimbic, unimodal association cortex. And so this is by a father of behavioral neurology, Meslam, in 1985. It's not a recent thing, it's an old thing. So now let us see the thought process, and this class is especially because of the Alzheimer's disease day on 21st. So how the thought is generated is the product of combined unimodal and heteromodal association cortices, and it is influenced by constant inputs from primary and supramodal association cortex. What does supramodal association does? It anticipates, conjectures, ruminates, plans for the future, and fantasizes. It brings specific cognitive processes to conscious awareness. So this is an important neurophysiological aspect of the association cortex. Association cortex is a very important aspect. How the neurophysiology of thought, this is primarily, it is processed by unimodal association cortex, that is unimodal percept. Sequentially, it is processed by anterior heteromodal association cortex. The cross-modal association is posterior heteromodal association cortex. This information is constantly, it is modulated by supramodal association cortex. So important thing for dementia is frontal lobes, and you should know everything about frontal lobes and what are the areas, what is the orbitofrontal doing, what is the medial frontal, what is the dorsolateral frontal functions. These are very important, and you can see the areas of Broadman areas. You can see the area 4, area 6, area 44, and area 8, which are depicted in this slide. And the main function of area 4, you know, is motor, and primary this area 6 and is premotor, and motor association cortexes are seen in the area 8 also. So these are the dorsolateral prefrontal cortex is shown here, 46 and 45 pars triangularis and pars orbicularis. These are important for the heteromodal association areas. These are all important for language and behavior. And you can see the anterior cingulate gyrus, which is also very important. Cingulate gyrus is just above the corpus callosum. It is a lateral orbitofrontal cortex, medial orbitofrontal cortex, and these are orbital regions are very important, as I show you next slides. And the impulsivity, the behavior, the social graces, all are in the orbital cortex. The medial frontal cortex and the anterior cingulate are what's the drive you have. They show that. That is the paralimbic medial frontal, the drive, the success, and the ones you want to study, you want to do this, they're all on medial run. If it is damaged, you become apathetic. So this is the frontal circuits which I was trying to drive into your brain, and you can have a look at them, and I've shown you this diagram number of times. So you just imagine this executive, apathetic, disinhibited. Disinhibited is orbitofrontal cortex. Disexecutive, dorsolateral cortex. Apathetic, medial frontal lobe. So the usual bedside tests which you can remember for working memory, digit span, time required 3 minutes. The mental manipulation is tested by reverse digit span. Visuomotor attention and such by trial CA, trial B test. Set shifting also modified trials test. Verbal memory, that is words, how many words you can write with D. And design fluency, that is you draw a circle, a triangle, a square and ask him to see for a minute and then draw them again. That is a visual memory testing. Concept formation you can do with the proverbs, and these are the important bedside dorsolateral frontal lobe system functions which I'm just briefly touching here. We'll go into the assessment at a later stage next class. So now after that, the important aspect of memory comes, and what's memory is very important. And memory has got what clinicians usually do is they do three types of memory tests, and those memory, what is memory, will see. What they do is immediate immediate registration. One, second, they do whether they are learning. Third, whether they are retrieving. So there are three aspects of memory, and if you can define, and memory is, as I said, is mediated by the Pepper circuit, and memory is receiving, processing, maintaining, and retrieving information. The main important thing is it is receiving, processing, maintaining, and retrieving information. That means it has to encode or acquire and register. That is registration, retention, it has to store, and it has to recall, retrieval. So all the three stages can be affected in diseases. So you can see the temporal stages of memory, that is sensory memory, immediate memory, recent memory, and remote memory. So these are the various aspects of memory that we can think and see. Why I'm saying is sensory memories are very brief, less than 1 second, 1 to 2 seconds, and that is your hearing and your audition or your visual memories. The frontal immediate memory is 30 seconds. So that is the working memory. You can keep plus minus 2 items to 7 uh, in briefly for 30 seconds. And if you are asked to dial a telephone, you listen to the telephone number, you dial and you forget about it. Right? When distractions are not there, you focus and learn and leave it. The minutes to weeks to months is a recent memory, which is requiring Pepper circuit to retain, to register, to store in the association cortex. This is required, and this is in the medial temporal lobe, and it is time locked, and it you have to know when it started. When is important here. The time is important. Where did you go last week, and what did you eat in the breakfast? And this memory is very important because Alzheimer's disease is characterized by loss of recent memory, and is also called episodic memory. The remote memory, this is large in the association cortex. I told you there are various areas of association cortex which are surrounding the primary sensory areas. Unimodal, heteromodal, supramodal association cortices are present, anterior and posterior heteromodal. So there the remote memory is stored. So higher cortical functions are disturbed mainly because of diseases in the association cortical areas. So you can see the long-term memory can be declarative, that is uh, semantic memory, and this is in the cortical association areas. The episodic memory is in the medial temporal lobes. The other important aspect is non-declarative memory, which is a procedural, that is skills and habits, priming neocortex, non-associative learning, and conditioning. These are the memories and these are present even in Alzheimer's disease. They can be trained, they can be taught to play, they can be taught to stitch. That they don't have to know how it is generated. So these are the semantic memory means sequencing facts. We'll deal with semantic memory and episodic memory in subsequent classes. When not this class will only mention briefly about them. So the UCLA memory test is a test which we should use in the bedside. It has got 8 words: cabbage, table, dog, baseball, showerlet, rose, belt, and blue. They are not related. You give one presentation and ask them how many he can, in any order they should remember. You give 4 presentations like that, and ask him to recall afterwards, and you tabulate them. Suppose if they are recalling only 3 3 4 3, then that is a problem of attention. That is their immediate, that's working memory is affected. If they are improving with each repetition, then that is a problem. That means there is no learning problem. If they are not improving, the graph is flat, there is a learning problem, or it is only attention problem. And third one is the retrieval problem. And if you recall is done after some time, 10 minutes or 15 minutes, when they do other tests, and if they are not able to retrieve the memory, that is a different set of diseases called retrieval memory. So there is a disease called amnesia, which is because of the medial temporal lobe damage and herpes simplex encephalitis and all disease. So recall will be affected here. Suppose if these items can be, can be recalled with cues, with one cue is a category clue, and the vegetable, furniture, animal, if they are able to recall, it's okay. There's subcortical dysfunction, not a primary cortical problems. The cueing helps in subcortical dementia, which is characterized by psychomotor retardation and the memory disturbance, which can be helped by cueing. It's not primary degenerative dementia. It could be because of vascular causes, Parkinson's disease and Huntington's disease. These are subcortical dementias. So now the language is another circuit which is a part of this, and you can see that Wernicke's area and these are the areas which we have already discussed. So we'll skip this, and now the language areas will this is what the visuospatial thing which I am trying to tell you. That's a what pathway and where pathway. These are the dorsal and ventral streams which are going to help us in our cognitive processes and the correct concepts. Now let's see of the dementia syndrome. It's cortical dementia, subcortical dementia, frontal lobe syndrome, amnesic syndrome, aphasic syndrome, that is primary progressive aphasia, age-associated memory impairments, secondary dementia, dementia with neurological signs, primary degenerative dementia. When a patient comes to us with disturbances in multiple domains, and what we should know is this is the chart we should keep in mind. So am I dealing with cortical, subcortical, frontal lobe, amnesia? Is it primary progressive aphasia? Or is it only secondary dementia, dementia with neurological signs and primary degenerative dementia? Because 10% of dementias are treatable. How will you differentiate subcortical from the cortical? The severity of dementia is very severe in cortical, so mild. The speed of cognition or information processing is normal in cortical, but it is slowed in subcortical. The frontal and the subcortical things help by cueing, whereas the corticals have aphasias, apraxias, agnosias. That's much more severe. The motor abnormalities like dysarthrias and rigidity are seen in subcortical. Gaggenhalten may occur in late stages in cortical dementias. The pathology, the etiology is Parkinson's disease, Huntington disease, PSP in subcortical, Alzheimer's disease in cortical and frontotemporal dementias. So these are the main differences between cortical and subcortical. You can see the gray matter abnormalities, that is Parkinson's disease, Huntington's, PSP, small vessel vascular, Wilson's disease. These are gray matter causes for subcortical dementias, small vessel vascular disease, MS, head injury, AIDS dementia complex, hydrocephalus, Binswanger's encephalopathy. All these things will cause dementia syndrome. But the primary degenerative dementias, Alzheimer's disease, frontotemporal dementia, Pick's disease, and dementia with Lewy body disease are the different set. The age-associated memory impairment. Now, we frequently come across these chaps who got complain of a decline of memory, but normal neuropsychological test results. And do they develop Alzheimer's disease if they have any extrapyramidal signs or a apolipoprotein genotype? They are likely to develop is associated with the Alzheimer's disease in the due course of time. So these are two important features which we keep in mind. So the patients complain of memory loss, but if the relations complain, then that becomes more significant. If he complaints, there is no problem. The criteria of minimum cognitive impairment is the memory complaint preferably qualified by an informant, not the patient. It is memory impairment for age and education. It should collaborate with the peers. General cognitive function is preserved, only memory impairment. There are intact activities of daily living and not demented. This was the earlier concept. But the these chaps, if they have got apolipoprotein E4 carrier state, hippocampi or atrophic on MRI, increased CSF tau, decreased amyloid beta levels, FDG PET temporoparietal hypometabolism, positive amyloid imaging PET scan, these are predictors of MCI going into the Alzheimer's disease. So these are important things. You can see next, the MCI can be classified like this. Cognitive complaint patient comes. It is not normal for age. He is not demented, but he thinks that cognitively he declined. Essentially normal functional activities. Then how do we approach? Is memory impaired? Yes. It could be amnestic MCI. Memory impairment only, then single domain. If there are other domains, it is multiple domain. Memory is not impaired, non-amnesic, single non-domain cognitive impairment, that is executive control function, visual spatial function, language disturbance, all can be, they can be multiple or single. So these are the important aspects that MCI has brought to us. So the etiology is amnesic MCI, single domain is Alzheimer's disease, multiple domain also this. But if multiple domains can be vascular cognitive impairment and pseudo-dementias also to be differentiated. The non-amnesic single domain is frontotemporal dementia, multiple domains is diffuse Lewy body disease and vascular cognitive impairment. Our problem is we have a rich load of vascular cognitive impairments which can coexist with Alzheimer's disease. Okay, so what is the important thing about frontal lobe syndromes? There's a marked personality change, distractibility, poor word list generation, poor recall with impaired recognition skills, impaired abstraction and judgment, abnormal motor programming abilities. All these things were dealt in detail, great detail in the lectures on frontotemporal dementia. And if you find any neurological sign, the primary degenerative dementias come down below. The presence of a non-cognitive neurological sign, involvement of parts of the cortex that are usually spared in primary dementias, and subcortical white and gray matters both affected, and prominent defective retrieval of material, and if there is a benefit from cues, retrieval cues, the poor recall with preserved recognition, memory, intact language functions, poor judgment, loss of abstraction abilities, prominent frontal system disturbances, all these things will tell us look for secondary causes, and degenerative dementias are incurable and treatable dementias you should be able to. Now that brings us to a very interesting syndrome called amnesic syndrome, which is the loss of a secondary stage of memory, that is recent memory, due to bilateral hippocampal damage, which can be seen in herpes simplex sufferers or Alzheimer's disease. These individuals, they are present always in present tense. There is a recent memory impairment, anterograde and retrograde, global amnesia, preserved immediate memory, preserved remote memory. They'll tell about all the things in the past. Intact general cognitive function. There is disorientation to time, place, and confabulation. If you look at them immediately, they will tell so many things. You never suspect that they have a problem. But if you start really, the moment he goes out of your room, he forgets everything. That's how you've seen in some couple of movies also. So the features of cortical dementia: prominent impairment in cognitive function without any abnormality in primary sensory or motor function. The attention is intact. This anterograde learning defect is there, which is poor learning, which we saw in Ookla test how to do. There's a fluent aphasia with anomia, impaired comprehension, poor calculation, disturbed abstraction, and judgment. So these are the important aspects that are present. And the This is a very important aspect. Cortical dementias to be differentiated from the treatable dementias, and usually they are asked, what are the treatable dementias? So, what is the relative frequency of causes of dementia? I said dementia is not a disease, it's a syndrome. Though frequency of Alzheimer's disease is almost very common, 50%. And it exists with vascular dementia in another 10 to 20. It is common. Treatable dementias are 10% but less common. The PICs, the NPH, the prion diseases and all are less than 5, which are uncommon in one study. But these things keep changing. We cannot be sacrosanct about it, but we try and rule out all the treatable dementias. And you should know what are the treatable dementias. The common causes, Alzheimer's disease has got amnesic multidomain dementia syndrome, posterior cortical atrophy, visual variant, logopenic aphasic variant, dysexecutive variant, apraxic variant, that is corticobasal syndrome, which we have discussed in other lectures because the Alzheimer's day lecture, so we are not going to the details of this. Dementia with Lewy bodies, vascular cognitive impairment, FTD, progressive non-fluent, agrammatic, semantic dementia, which is because of anterior temporal lobe problems, frontotemporal dementia, behavioral variant, and ALS and dementia complex. So these are the important primary degenerative dementias which will come to our attention. And as this is the thing which I showed you in the numbers, so we'll skip this and go to the next slide. So episodic memory impairment is a key feature of Alzheimer's disease. And semantic memory impairment is a feature of frontotemporal dementia. How do you test? Ask him to tell the months in order. He will not be able to tell. The week, days in order. He will not be able to tell. So the main diagnostic challenge for us is the coexistence of vascular disease with Alzheimer's disease in our country. So episodic memory is tested, as I said earlier, by time locked. So AD is a pathologically heterogeneous entity, and it can coexist with so many diseases: diffuse Lewy body disease, vascular dementia, and Huntington's disease, PSP. It can have, so in one large study which was published in 97, 694 subjects. Out of that, only 36% were pure AD, and remaining things have some coexisting things that are pure. So this point is very important. The treat 10% are treatable. The possibility of treatable dementias coexist with primary dementia should always be kept in mind. Suppose you diagnose a case with Alzheimer's disease, suddenly he deteriorates. He may have developed subdural hematoma. Please get a CT scan done, non-contrast. So, what are the causes? Pseudodementia depression is an important cause. Medication encephalopathy. Look at the list of the drugs he is taking. Hypothyroidism, B12 deficiency, hyponatremia, that is metabolic disorders, ICSOL, which is resectable, subdural hematomas, NPH, chronic meningitis. Don't forget any of these. These are often asked. What are the treatable causes? You have to look for treatable causes. And the medication encephalopathy can be a cholinergic antagonist, especially pacitane. Don't give beyond 16. You don't know what they're suffering in the night. Benzodiazepines, barbiturates, narcotics, histamine antagonists, digoxin, dopaminergic antagonists, the narcoleptics. So these are the medication encephalopathy medications. So that's all from my side today, and we finish here. Thank you very much for your attention. This talk is basically because of Alzheimer's disease day, and next week onwards we'll have regular cognitive neurology classes and other neurology classes, and also research methodology and electrophysiology. Yes, Gopi, you can unmute, and yeah, you can. Any message? Okay, thank you very much. If there are no questions, then We'll say bye bye to you, and we'll meet next week. Thank you.